very much, Dr. Arti, for the kind words. It's a great pleasure to give this presentation. Good afternoon, everyone. In the coming 20 minutes, I'll be talking about recent guidelines and emerging therapies in the treatment of bullous pemphigoid, pemphigus vulgaris, and pemphigus foliaceus. To begin with, bullous pemphigoid is the most common autoimmune blistering skin disease. It runs a chronic course with spontaneous exacerbations and remissions. It mainly affects elderly and is associated with increased morbidity and mortality. Old age, Parkinson's disease, heart failure, chronic renal disease, and the use of high doses of systemic steroid are associated with increased mortality. The 3-year mortality rate is about 45%. The main causes of death are pneumonia, cardiovascular disease, and stroke. Bullous pemphigoid is associated with tissue-bound and circulating autoantibodies directed against BB180 and BB230, which are components of hemidesmosome. The patient can present with non-specific symptoms prior to the appearance of blisters, such as pruritus, with or without excoriated eczematous, papular, and urticarial lesions. Bullous pemphigoid is classified into mild, moderate, and severe disease based on the affected body surface area and the bullous pemphigoid disease area index score. Why this is important? Because treatment of bullous pemphigoid depends on the disease extent. In case of localized bullous pemphigoid, in which lesions involve one body site, or mild bullous pemphigoid, in which less than 10% of the body surface area is affected, it is recommended to apply topical potent or superpotent steroid to the affected lesions. Studies have shown that applying clobetasol propionate for bullous pemphigoid in mild and localized cases to be equally effective to oral prednisolone. In moderate disease, in which 10 to 30% of the body surface area is affected, topical clobetasol propionate should be applied to the affected area with or without systemic steroid. In severe cases, where more than 30% of the body surface area is affected, a combination of systemic therapy with topical clobetasol propionate is recommended. The patient should apply 30 to 40 grams of clobetasol propionate per day, divided into 2 daily applications on the entire body except the face and anogenital area. The first-line systemic therapy is prednisolone 0.5 milligram per kg per day. However, up to 50% of patients relapse during steroid tapering, therefore requiring adjuvant treatment such as azathioprine, dapsone, doxycycline with or without nicotinamide, methotrexate, and mycophenolate mofetil. As we all know, treatment with oral steroids and immunosuppressants is associated with an increased risk of infections and sepsis. Additionally, long-term use of systemic steroids may cause significant side effects such as insulin resistance, osteoporosis, cataract, and glaucoma. And I think Dr. Hashimi will talk into more details about the use of systemic steroid in autoimmune bullous diseases. How effective is doxycycline treating bullous pemphigoid? In this randomized controlled trial, 253 patients diagnosed with mild, moderate, and severe bullous pemphigoid were enrolled into doxycycline group and prednisolone group. The results showed that the proportion of patients achieving treatment success in 6 weeks was 74% in doxycycline group compared to 91% in prednisolone group. And the proportion of patients experiencing treatment-related adverse events by 52 weeks is 18% for doxycycline group compared to 36% for prednisolone group. There were 3 treatment-related deaths in doxycycline compared to 11 deaths in prednisolone group. So starting patients on doxycycline is non-inferior to medium dose of oral prednisolone for short-term blister control in bullous pemphigoid, and it is significantly safer in the long term. Unfortunately, up to 24% of bullous pemphigoid patients do not respond to conventional therapy consisting of oral steroid with or without immunosuppressive agent. In this case, we can consider IVIG, plasmapheresis, rituximab, omalizumab, and dupilumab. When to give IV immunoglobulins? IVIG is indicated in case of extensive or debilitating disease, inability to achieve a sustained remission 6 months after conventional therapy, recurrence of disease upon upon withdrawal of medications, systemic steroid dependency, significant side effects from conventional therapies, and if other options are unavailable or contraindicated. 211 patients were included in a systematic review. They were diagnosed with bullous pemphigoid, and they failed conventional therapy, including IVIG. 122 patients received rituximab, 53 patients received omalizumab, and 36 patients received dupilumab. The review has shown that rituximab, omalizumab, and dupilumab have similar clinical benefits, and patients who received them were able to achieve remission within an average of 4 to 6 months. The recurrence rate was approximately 20% in rituximab group compared to 5% in omalizumab and dupilumab group. The most common adverse event was infection in rituximab group. There were no reported deaths or adverse events in dupilumab group. Why do we use omalizumab in treating bullous pemphigoid patient? IgE deposition was observed in the basement membrane zone in 41% of bullous pemphigoid patients. Those patients have higher bullous pemphigoid disease area index compared to the patient without IgE deposition. Omalizumab leads to bullous pemphigoid remission by directly blocking the binding of anti-BB180 IgE antibodies to their high-affinity IgE receptors of mast cells and eosinophils, thus inhibiting inflammatory cell activation, tissue damage, and blister formation. Studies have also shown that serum total IgE levels were elevated in 64% of bullous pemphigoid patients. Although high serum level of IgE correlates with disease severity, baseline serum IgE and eosinophil levels are not required before starting omalizumab because they did not predict the treatment response. How can dupilumab result in BB remission? As we all know, dupilumab is interleukin-4 receptor alpha antagonist that blocks interleukin-4 and 13, thus inhibits B cell proliferation, eosinophil chemotaxis, and T helper 2 chemokines. In the coming slides, I'm going to present two cases of our hospital diagnosed with bullous pemphigoid and treated successfully with dupilumab, 600 milligram loading dose and 300 milligram every other week in combination with topical clobazole propionate. This is the first case, and this is the pictures 4 months after. And this is the second case, and as you can see, 2 months after dupilumab, there is almost complete remission. JAK inhibitors and bullous pemphigoid. Elevated expression of JAK-STAT proteins have been found in lesions of patients with bullous pemphigoid compared to controls. So based on this finding, the disruption of JAK-STAT signaling pathway may inhibit autoimmune response in bullous pemphigoid with subsequent reduction in the development of bullae. A case report was published in JAD regarding the efficacy of upadacitinib, which is a selective JAK1 inhibitor, in the treatment of 81-year-old lady with multiple comorbidities who was diagnosed with bullous pemphigoid, for which she received prednisolone. Prednisolone was tapered 20 days following upadacitinib initiation. The dose was 15 milligram per day, and as we can see, 5 months after the treatment, there is complete remission. Baricitinib successfully treated an 83-year-old Chinese man, known case of psoriasis. The patient diagnosed with bullous pemphigoid and received baricitinib 4 milligram per day for the first 12 weeks and then 2 milligram per day for the following 12 weeks. He showed a complete remission of both bullous and psoriatic lesions without any adverse events by 24 weeks. JAD also published 2 cases of bullous pemphigoid which were refractory to conventional therapy, and they were effectively treated with tofacitinib, a pan-JAK inhibitor, 10 milligram orally for twice per day. And this is the second case. As you can see, there is complete clearance of skin lesions and pruritus as early as 3 weeks. So JAK inhibitors are promising. Understanding the pathogenesis of bullous pemphigoid have enabled the investigation of new therapies which work against a variety of pro-inflammatory mediators associated with bullous pemphigoid. We know that bullous pemphigoid is characterized histologically by inflammatory infiltrate rich in eosinophils. Peripheral eosinophilia has been reported in 50 to 70% of bullous pemphigoid patients. Increased expression of eutaxin-1, which is a eosinophil chemoattractant, has been demonstrated in serum, blister fluid, and perilesional skin of bullous pemphigoid patients. Based on these findings, benralizumab, bertelimumab, and mepolizumab, which target eosinophils, are under investigation as potential treatment for bullous pemphigoid. Let's turn now to pemphigus. Pemphigus encompasses a heterogeneous group of autoimmune blistering diseases. It runs a chronic relapsing course and affects the patient's quality of life. Pemphigus vulgaris is the most common type of pemphigus, and it is a life-threatening disease. IgG autoantibodies binding to desmoglein 1 and 3 causing acantholysis, which results in flaccid blisters and erosions of both mucous membranes and the skin. ELISA is positive in 95% of pemphigus cases, and anti-desmoglein antibody values correlate with the disease severity. With the introduction of systemic steroid, the one-year mortality rate of pemphigus has dropped to 5%. Most deaths occur due to the adverse effect of immunosuppressive agents. Pemphigus vulgaris and pemphigus foliaceus are classified into localized, mild, and moderate to severe. In case if the patient presented with erosions and blisters that affect up to 1% of the skin, or mucous membrane involvement, which is up to 1 centimeter, this is considered a localized pemphigus. In mild cases, the body surface area is usually less than 5%, and pemphigus vulgaris patient may have limited oral lesions, not impairing with food intake or requiring analgesics. In moderate to severe cases, the patient or the skin of the patient usually covered with blisters and erosions, and more than 5% of the body surface area is affected, with or without multiple mucosal involvement, severe oral erosions, dysphagia, weight loss, and significant pain. Dr. Jassim will talk into more details about oral manifestations of autoimmune bullous diseases. Treatment of pemphigus vulgaris and pemphigus foliaceus depend on the extent of the disease. Induction therapy for mild pemphigus vulgaris and foliaceus needs a combination of systemic steroid and adjuvant therapy such as azathioprine, mycophenolate mofetil, mycophenolic acid, and dapsone. You can start the patient with prednisolone 1 to 1.5 milligram per kg per day, or its equivalent, or you can give the patient IV pulses of dexamethasone 100 milligram per day for 3 consecutive days, every 3 to 4 weeks initially, and every 6 to 8 weeks subsequently. The first-line treatment of moderate to severe pemphigus vulgaris and pemphigus foliaceus is rituximab, 1 gram, 2 weeks apart, in combination with systemic steroid. If rituximab is contraindicated or not available, then a combination of systemic steroid with immunosuppressive agent is recommended. If the patient doesn't achieve disease control within 3 to 4 weeks, then we have to increase the dose of prednisolone to 1.5 milligram per kg per day, or we can add rituximab. If complete remission is achieved, then we have to taper the systemic steroid over 6 months following the initial cycle of rituximab. We can give the patient 500 milligram of rituximab at month 12 and 18. Additional infusions of rituximab after month 18 is given only for the patients with re-increase of anti-desmoglein antibodies after their initial disappearance. What if the patient achieved complete remission, but he presented initially with a severe pemphigus and or still have high rate of anti-desmoglein antibodies by month 3? Then we have to consider giving the patient rituximab infusion 500 milligram to 1 gram at month 6. If partial remission is achieved after 6 months, consider another cycle of rituximab. If the patient relapses after complete remission during the first 4 months, in which we usually taper the prednisolone, you can re-increase oral prednisolone. But if the patient relapses 4 to 6 months after the initial cycle of rituximab, then you have to consider another cycle of rituximab. In this randomized trial, 90 patients with newly diagnosed pemphigus vulgaris and pemphigus foliaceus were randomly assigned to prednisone group and rituximab plus short prednisone group. The study showed that at 24 months, 34% of patients in the prednisone arm achieved complete remission compared to 89% of patients in rituximab and prednisolone arm. More severe adverse events were reported in prednisolone alone group than in rituximab plus prednisone group. So first-line use of rituximab plus short-term prednisone is more effective and is safer than high-dose prednisolone. For severe cases of pemphigus vulgaris that cannot receive rituximab or immunosuppressive agents, or they did not respond to them, you can consider IVIG or plasmapheresis. It's recommended to monitor the level of serum autoantibodies by ELISA or indirect immunofluorescence at the initiation of treatment, after 3 months, and every 3 to 6 months thereafter. Discontinuation of a treatment is primarily based on the clinical symptoms in combination with anti-desmoglin antibody levels, which is measured by ELISA or indirect immunofluorescence. Discontinuation of systemic steroid may be considered in patients in complete remission on minimal therapy and they have negative circulating anti-desmoglin antibodies. It's recommended to stop immunosuppressive agents within 6 to 12 months after achieving complete remission on therapy. Coming to the last point of my presentation, this slide summarizes the targeted therapy which are under clinical trials or applied in practice for the treatment of pemphigus vulgaris and pemphigus foliaceus, such as new generation or second generation anti-CD20 antibodies, anti-CD19, anti-CD25, anti-IL-6, CAR therapy, and Bruton's tyrosine kinase inhibitors. Bruton's tyrosine kinase inhibitors are promising in the treatment of chronic spontaneous urticaria as well as pemphigus cases. That brings me to the end of my presentations. Thank you very much.